Invitamos al doctor Alexandre Fortes. El doctor Alexandre Fortes es un médico especialista en medicina musculoesquelética. El doctor Fortes, su idioma natal es el portugués. Él viene de la República del Brasil y el nombre de su conferencia es Medicina musculoesquelética en atención primaria en salud, un abordaje integrativo. Doctor Fortes, bienvenido.
Thank you. I speak Portuguese. My Spanish is very terrible, so I'm going to spare you the suffering and use my English, which is better. So my specialty is family medicine. I'm not specialized in musculoskeletal medicine, but inside family medicine, we can do a lot of stuff. We take care of children, elderly, small surgery, and a whole bunch of stuff. I am passionate about musculoskeletal medicine. And since I started gazing upon this chapter of my life, I've learned a lot. And one of the things I learned is, this is difficult, very difficult. So I'm using this picture to symbolize what I'm trying to say. It's a puzzle. Every pain case is a puzzle in which we have to bring the pieces together and try to see the big picture instead of just giving the painkillers, which don't do much use. So I divided this lecture in a few chapters for us to understand where we stand today. First of all, in med school, this is a study from the 60s where they took 1,000 patients and they watched what happened over the period of 1 month. So in 1 month, approximately 750 adults reported one or more symptoms. 250 of them consulted a physician. 9 of them were admitted to a hospital. Only 1 out of 1,000 was admitted and internalized in a hospital, a university hospital. Now take this inside of you. Where did we all learn? In med school, we attended a university hospital. Therefore, all the patients that we accompanied or learned with represented 0.1% of what's actually out there. My students, when they are accompanying me in primary care and they see a lumbar pain patient, and they're like, is this spondylitis? It could be a spondylitis and callusitis. I'm like, don't think of the worst things. Think of the most common. Well, it turns out the same research was conducted in the year 2001. And again, they took 1,000 people and they watched what happened over the period of 1 month. And again, only 1 or less than 1 out of this 1,000 was hospitalized in a university hospital, which is the grounds for us to learn. In a study in Canada, they evaluated the med school training. Over the period of 6 years of med school training, graduate school, they estimated that every student was exposed to approximately 6 to 12 hours of studying the musculoskeletal exam. 6 to 12 hours in a period of 6 years. Now, when he graduates, and whatever it is he's going to do afterwards, surgery, pediatrics, gynecology, whatever, he's got approximately 6 to 12 hours of training. And pain is the second most common cause of consultation. Doesn't make sense. So this is us in the first year of med school. We learn to do what they teach us. We don't learn to think, most of us. This is a study from 2015 where they did magnetic resonance imaging of everybody, asymptomatic patients, from 20s to their 80s. And they found that everybody, I mean everybody, had something to show on their MRI. This is a concern because based on the exam, the next step is to treat. And what we've been taught in med school is treat with painkillers and so forth. And the result we've seen today is the opioid crisis that's been challenging the United States. The main cause of death in adults over 50 years of age today in the United States are due to opioid overdoses. Why? because nobody taught us how to treat pain. This is a picture of what's been happening and what's going on. And this is something that's got to stop. Really, we've got to do something about this. So people are used to think of musculoskeletal pain as this. Oh, this hurts, take this pain, it'll be okay. A linear thing, like natural history. But in fact, when we're talking about pain, it's a little more complicated because there are a lot of other things that come to mind when evaluating the experience of pain. Pain can be something organic. I may have a broken arm, a splinter, a burn. It may be something emotional. Anyone here ever been depressed? It can be psychological. Just look at a child before being vaccinated. She's in frank suffering. So pain is it's a non-pleasant experience due to a potential harm or real harm in the body, in the mind, or in the soul. But we've been taught to treat the body and forget the rest. So why do some patients don't respond? Here we have the funnel of pain. We treat everybody the same. Painkillers, opioids, corticosteroids, and some patients don't respond. So why? Maybe we're treating wrong. Maybe the diagnosis is wrong. Maybe there's a lack of correction. For instance, the patient's doing repetitive motions, repetitive movements every single day with a bad posture, and that puts on strain on the body. So you've got to correct that. Or maybe somebody has secondary gains. So when we're evaluating pain, there are a lot of fields that we have to encompass. We have to think about the cognitive. We have to think about the behavior, social, cultural, affective, sensitive, and physiological. Since I'm a family doctor, I'm not what we would say a traditional doctor. I used to be an emergency doctor before. I used to treat just like everybody else. And when I got to know that the patients I used to treat at the emergency room came back week after week with the same kind of decompensation, I decided to change. I decided I want to make a difference. I want to make it so that the person doesn't have her diabetes decompensated again. I don't want to see another crisis and so forth. So, coming back to our subject, which is pain. Recently, using Netflix, I watched this series, Vikings. Anybody here watched it? Okay, fine. Maybe you'll get what I'm saying. What caught my attention was the experience of pain for them and their culture was extremely different than the ones we have. For a Viking to go to heaven, he would have to die gloriously in battle. That means he could not express pain or weakness. So, if he experienced pain, for instance, he got slashed or bones crushed or anything, if he started weeping or crying or expressing pain, everybody would look to him as weak, and so would the gods, and then he would not go to heaven. So they looked at pain as a challenge. I'm going to show everybody that I can take it, and I'm going to heaven. That is completely different from what we have today. Today, oh, my back hurts, I'm not going to work. No, I can't do this, I can't do that. And we victimize ourselves. Okay, chapter 2. That was one thing. Well, how we learn about pain. Chapter 2, we're going to talk about the burden of musculoskeletal medicine conditions. The age where people most commonly present musculoskeletal pain is between 40s and 60s. That meaning the top productive age in a professional career. And the person has to stay some days or months or weeks away from work. This subject is so important that the United Nations declared the decade of 2010 as the bone and joint decade in an effort to bring to the light a subject that has been not so popular. In the United States, 2015, they started asking people, do you have any chronic diseases? Oh yes, I have this, I have that, and this is what they came up with. Musculoskeletal pain or problems was much more prevalent than hypertension, diabetes, cancer, asthma, much more prevalent. And we also know statistically that we are getting older, but that doesn't mean we are getting better. Our bone matrix, our skeleton, our body maybe was not designed to last this much, but our great advances in medicine have made it possible for us to live longer, but with a decaying body. Prevalence of self-reported limitations in activity. Well, I can live maybe 90 years of age, but how am I going to live that? Am I going to live that happily? Or am I going to live coming and going to the hospital, taking meds, being hospitalized, or whatever? The quality of life, that's what I'm talking about. Living better is not the same thing as living more. And funding. Nobody wants to spend money studying pain. See, all other conditions get more money to study, but pain, nobody gives. In the UK, $7 billion a year is the estimated costs of musculoskeletal pain. Now, let's take this again. We said that 1% of the patients are hospitalized in a university hospital. That's where med students learn. Med students learn based on the exceptions, not the rule. So they learn about rare diseases. We know that many exams tend to say what the person has, but not really. We know that exams can pick up a lot of details, but that doesn't necessarily mean that that is the cause of suffering or pain. And we know that based on these rare exams and diseases, we make protocols so we don't get mistakes. And these protocols tend to treat the symptoms, not the person. So we have direct and indirect costs of bad management of pain. Direct costs, the hospital bill, the medications I have, the physical therapist, the days away from work, and so forth. Indirect costs, loss in quality of life. Has anybody here ever had pain every day for at least 1 month? Please raise your hand. Okay, so maybe 1 or 2 of you know what I'm talking about. Imagine this, waking up in the morning, grumpy, feeling pain, uncomfortable, and somebody comes up to you and says, "Good morning," and you're like, "Ugh." That's not quality of life. Nobody wants that. Chapter 3, the causes. Why is this so prevalent? Well, in this study, we've seen a number that shows that musculoskeletal conditions are on the top shelf. And here we have chronic joint pain, lower back pain, arthritis, neck pain, carpal tunnel syndrome, lower back pain. And maybe this is why our culture is not worried about our body, but about our pleasure. So we tend to get sloppy, and we forget about doing what needs to be done. I usually tell my patients, "You have a car, right?" "Yeah, I have a car." "Do you take it to the shop from every here and then?" "Oh yeah, I go every 3 months, I take my car to the shop, I change the oil, I do everything right." Why don't you do the same to yourself?" And they're like, "Yeah, I didn't think about that." So somewhere along the evolution, we did something really wrong. And maybe we have to go back to the basics. I use this example very often. When you hear galloping, you know galloping? We usually think about horses, right? Why not think about zebras? They also gallop. Most universal healthcare systems are based on this pyramid, on primary care, secondary care, and tertiary care. Primary care would be this piece of the cake. Most of the patients. It's a headache, a stomach ache, a mild pain, a migraine, simple things. When somebody has something, a condition or a symptom that it's a little bit weird or hard, we tend to refer them to the secondary attention. And when it needs surgery or hospitalization, it goes to the hospitals. So primary care is the horse. Hospital is the zebra. But we are teaching our students about zebras and not horses. So when they hear galloping, the first thing they think of is the zebras. So again, the protocols are based on rare diseases, the zebras. Young graduates tend to look for zebras instead of horses. Consequently, they ask a lot more exams, they prescribe a lot more medications, and they are much more iatrogenic. They make much more mistakes. So what about our horses? Who takes care, who listens to horses? Well, I have to say, I'm a family physician, I do. So going back to the basics, does anybody have a clue? Does anybody doubt that brushing our teeth every day is important? Does anybody still argue that this is supposed to be done? No, just do it, right? Okay. So prevention is basically what's going on and working. Stop smoking, stop heavy drinking, use your seatbelts, lose some weight. Everybody agrees that this is a good option, right? Well, why not use the same logic for the musculoskeletal system? So stretch, strengthen, take care of your posture. Eat good foods. May your food be your remedies and your remedies be your food. We have to go back to the basics as doctors. We have to start to listen to doctors. On average, there's a study that says that every 7 seconds, a doctor interrupts his patients during the first exam when they're talking. So the patient comes in, oh, I have a headache. Oh yeah, what type of headache? Oh, I have a headache that's on this side. Does it hurt like this or does it hurt like that? And so forth. We don't listen enough. We have 2 ears and 1 mouth, and that should say something. We are here to listen more and speak less. So in this classical picture, we here see the doctor just looking and observing. This is the origin of medicine. Medicine came from observation, and from that conclusions and thought. And here you see the parents desperate, but trusting this fellow old man. We've lost that. We've given all that credibility to the exams, but the exams don't tell the truth. So we must go back to being the doctor who deals with health issues, functional abilities, who thinks about the financial positions, the support system, what situation the patient is living in, the family dynamics, and so forth. Because all of these will in some way or somehow influence on the experience of pain or suffering that they are going through. So this is the core of family medicine. In case none of you have ever had any contact with a family medicine doctor, this is the core of every family medicine. We are based on a certain type of attitude, on a science context, on a holistic approach, on a biosocial care, broad management, not just the symptom, but the person as a whole. When somebody asks me, oh, I'm a specialist in cardiology, I'm a specialist in pediatrics, what are you a specialist? I'm a specialist in people. And that's the simplest way of telling you guys what I do. I specialize in people, and everyone is a single one. I don't treat everybody equal. So, going back to pain, what would be an integral approach to MSK conditions? Well, we have a physical therapist, we have the orthopedics, we have acupuncture, physical rehab, rheumatology, chronic pain. All of them treat pain patients. Where do I come in? Medicina de familia, family medicine. We have to have a little bit of everything. Example, I don't have to be a cardiologist to treat a mild hypertension. I don't have to be an obstetrician to accompany a pregnant woman in her prenatal care. I don't have to be an endocrinologist to manage simple diabetes with no risk. In the same instance, I don't have to be any of these specialties to treat a low back pain, an acute low back pain, a non-specific acute low back pain. Get what I'm saying? We're getting there, right? So we have to treat the person as a whole. We have to treat them with a little more compassion, with a little bit more love, because we're people, we're not machines. And that tells something about our medicine. Our medicine is very sick, and nobody looks at that. Let's get back to being doctors and stop being prescribers, because that's not working. like this guy. He's my hero. He treated people like people. Everybody knows Patch Adams, right? Okay. So getting all of this together, I started teaching family doctors or primary care doctors on how to deal with, how to examine, how to evaluate somebody with musculoskeletal pain. And I started back in 2010. And I went to every single Congress and never, ever, nobody was ever interested in this subject. So I said, well, why not me? After all, I'm interested. Then I started. And people became interested. And year after year, more and more people came to me looking for help. Oh, I always get desperate. That same patient is always coming back again. I don't know what else to do with her. Okay, let's start with the basics. Do you remember anatomy? Let's go back to our anatomy. So if you don't know anatomy, you're not going anywhere. So getting back to the basics, touching the patient, looking, observing, it has to be practical. It can't be theoretical. If you want, you can go online on YouTube. You can see every single exam, how to perform, but that's not what people want. People want to be treated as people, as much as us. We are also people. So after I started this program of training the family physicians, I started seeing some great results. In Florianópolis, where I'm from in Brazil, we used to have an escalating number of patients with low back pain. And these are official numbers from the county health office. And this year, between 2012 and 2013 is when we began training the doctors. And then we see a drop in the referral to orthopedic surgeons. Because most of the people just do this. Oh, I have a pain in my shoulder. I'm going to subscribe you some pain medicine. I'm going to ask for an exam, like an ultrasound, and go to the orthopedic surgeon. When the orthopedic surgeon looks at that, he says, well, this is not surgical. This is not with me. Go back and look for the physical therapist. And this takes time between one consultation and the other, and the patient is feeling pain every single day. And when he finally starts his treatment, it's already chronic pain, which is another big problem. So this is just to show the 10 top MSK conditions. This articular pain, low back pain, member pain, cervical pain, dorsal pain, pain on the shoulder, pain. They're the most common ones. And the most common referrals, they're also the same. And these are the exams, the imaging tests most solicited. Now these three, the ultrasound, a lumbar x-ray, and a knee x-ray were the top three. These three accounted for 60% of all the exams. Now I ran some numbers. I estimated about the value of each of them. And these three exams per year would cost about $500,000 for our community, which is small. Florianópolis is an island with about 400,000 people, so it's not that big. So these three exams are useless in the primary care setting, and we can save a lot of that. This is my personal history, as when I started in this subject in 2010, I referred about 60 patients to the orthopedic, and to the physical therapist, maybe around 5. The more I studied, the more I learned, the more I realized that the orthopedic surgeon is a surgeon. Therefore, he doesn't have to receive the patients with bursitis, tendinitis. That's not with the orthopedics. That's more for the physical therapist. So my referrals to the orthopedics dropped, and my referrals to the physical therapies increased. Well, you can say, well, didn't change much. You're still referring a lot of patients. But in the year 2015, I had the opportunity to take a course in the treatment of pain using acupuncture and dry needling. Then the referrals to the physical therapist dropped drastically. And that's when I saw the magic. Combining posture orientation, losing weight, exercising, using acupuncture, eating healthy, the number of patients that needed a referral dropped considerably. I'd say about 90% are over that, with simple things. Just as simple as buckle up that belt or stop smoking. It's that simple. lose some weight, and you help the patient do that. Now, why do I think that the family physician should be one of the best doctors to treat and accompany somebody with pain? Because we treat them from birth to death. We know the whole family. They live next to our office. So we see them on a regular basis, and it's always the same patients. We know all of their histories, and they really trust us. There's a bond, a really strong bond, which is very strong. When we're talking about the emotional and the cognitive aspects of pain, nobody better than the one you trust, the one who takes care of you in a loving manner, in a kind manner, in a human manner. That makes a lot of difference. Well, coming back to here, in the year 2014, the health secretary awarded this initiative, and then I started training all the doctors in Florianópolis. Afterwards, the Brazilian Society of Family Medicine recognized the excellence of this course, and now the diploma has their signature. And I'll leave you to this. Sometimes we may cure, sometimes. Most of the times we can prevent, but to care, we are always obligated to care. That's what makes us doctors.